you activate the cath lab, you call the cardiologist, come, and this patient, the heart muscle is dying, so we need to open the occlusion now. So you activate the cath lab. This is one of the indications where you activate the cath lab. Okay, that's what you have to know about ST elevation MI. Medications, you can learn them later, but that's the most important thing, activating the cath lab. Now, let's move on to acute pericarditis. Now, pericarditis is often confused with ST elevation MI, so I'll try to teach you how to differentiate the two. So it's an MI mimicker, and what you see is usually you see ST elevations and diffuse ST elevation. So in order to differentiate it between MI, from MI, look for PR changes. I'll show you in the next ECG. So this is a patient who presented with chest pain. So I can see ST elevation, clearly ST elevation, like this is the isoelectric line. You can see ST elevation in lead 1, ST elevation in lead 2. There is no ST elevation in lead 3. You can see ST elevation in V4, ST elevation maybe in V5, ST elevation in V2, V3. So should I activate the cath lab because there are not diffuse ST elevation? This patient might have an MI. The answer is, the answer is no, because look for other things that suggest other things. For example, one of the differentials of diffuse ST elevation is pericarditis. So in order to recognize pericarditis, look at the PR segment. So this is a diffuse ST elevation. The next step is going to be look at the PR segment. So the PR segment is between the P wave and the beginning of the QRS. So now compare the PR segment to the isoelectric line. So the isoelectric line in the PR segment, you can see the PR segment is a bit depressed. Look at this isoelectric line and the PR segment. So the PR segment in lead 1 is depressed. And lead 2 is even more clear, is depressed. Look at lead AVF, it is depressed. So you have ST PR depression in the inferior leads. And the most important thing, look at AVR and look at the PR interval here. The PR interval is elevated. So diffuse ST elevation, PR segment depressions, and PR segment elevation in AVR. Those three things tell you that this ECG is not due to an MI. Those abnormal ECG is due to pericarditis. One of the things that can help you as well is the shape of the QRS. So compare this shape of the shape of the ST segment. So compare the shape of the ST segment here and the shape that we saw during MI. So that's this concave shape of ST segment tells you it's more of other pathology rather than MI. But I don't use this method because it's in specific. Now in the exams, when you get a pericarditis case, they're gonna give you some additional information. So they want you to reach a diagnosis of pericarditis. So look for other things. So to diagnose pericarditis, you need 2 out of 4 things. You need to have a topical history. You need to have a pericardial rub. You need to have a pericardial ECG changes that we just saw. And you need to have a pericardial effusion on echo. So in the exam, they're going to give you a patient with positional chest pain. So positional chest pain, look for pericarditis, see the ECG. If there are diffuse ST elevation, then that's pericarditis. Let's move on to left ventricular hypertrophy. So left ventricular hypertrophy, the thickening of the left ventricular muscles. So this disease or those changes are usually due to hypertension and hypertrophic cardiomyopathy. Now, in order to diagnose it using the ECG, you have a certain criteria. and that criteria is a bit lengthy, so I'll teach you one simple method you can know. So the first thing is look. So let's apply it in the ECG. So you have an ECG, and you can the first thing that you can notice is the high amplitude you can see in the anterior pericordial leads. Look at those very large QRSs, very large QRS complexes. So the criteria to diagnose left ventricular hypertrophy is you count, you see lead V2, you see the S waves or the QRSs which are down. We call them S waves because they are after the R waves. And you count how many big boxes are they covering. So this first big box, second, 3, 4, 5, 6, and there is 7 here, maybe 8. So this eight big boxes, and then you add the number of big boxes that are covered by the QRS on V6. 1, 2, 3, 4. So 4 plus 8, that is 12. You need more than 35 small box. So now we have 12 big box, and each big box has 5 small boxes inside. So 12 multiplied by 5, that's 60. So that is left ventricular hypertrophy. Again, you count the number of you count the number of small boxes between in the R wave of V6, which is the QRS here, and the QRS of lead V2. Now the criteria says more than 35 small box is definitive of LVH, left ventricular hypertrophy. Now, in order, a simple way of counting the small boxes is to count the big boxes and multiply them by 5. So this is what I do. You can count the small boxes. You can count the small boxes here, and you add them together, more than 35, and that's gonna be LVH. So that's the criteria. You take V2, you take V6, or you take V1 and you take V5. You can do any one of them. Now, the last thing is bundle branch blocks. Now, bundle branch blocks, they are very common in exams, especially internal medicine and the clinical years. They love it a lot. And even you see it very commonly in clinical practice. So bundle branch blocks. So what you see is here the conduction system of the heart. We start with the sinus node. You go to the AV node, and then you have an AV bundle. We call it the bundle of Hess, and that divides into the left bundle branch and the right bundle branch, and both of them supply the ventricles through the Purkinje fibers. So that's basically it. Now, when you have an ischemia or you have a lesion that is interrupting one of the pathway, you get a bundle branch block. Now, think about it. The electricity moves from the sinus node to the AV node, then they move toward the bundles at the same time. So both ventricles contract at the same time. But if one of the bundles get interrupted, there's gonna be interruption in the timing of the ventricle. So one ventricle is gonna be contracting before the other ventricle. Because the QRS complex represents the ventricular depolarization, and one ventricle is getting depolarized after the other, that is gonna represent as a white QRS complex. We're gonna see that in a minute. So bundle branch block. So what's the most why it's important? Because in cases of left bundle branch block, if the patient had a left bundle branch block and chest pain, that qualifies as a STEMI. Okay, new left bundle branch block with chest pain. In cases of, I'll explain that point later. So now let's move on to the ECG, and I'll tell you how to recognize them. So they tell you in the table, you can tell you that that's the weak criteria for diagnosing left bundle and right bundle. For me, I'll teach you a very simple way to recognize left and right bundle branch blocks. So that's the ECG, okay? So the first thing, you look for the QRS. Is the QRS white or not? So you see here, the QRS is white. White is more than 3 small boxes. So this QRS is white. This QRS is white. Every QRS here is white. So go to V1. White QRS more than 120 millisecond, more than 3 small boxes. Then you look at the QRS. Is it pointing down or it's pointing up? If it's pointing down, then that's left bundle branch block. If it's pointing up, that's right bundle branch block. You don't worry about the M shape and the RSR complexes. Forget about all of that. Just do what I say. Look at the QRS. If it's down, left. If it's up, right. Okay. So in this case, the QRS is wide. You look at the V1, the QRS is down. So this is left bundle branch block. Now, if this patient presented with chest pain and that ECG is new, the left bundle branch block is new, then that patient is going to be treated as a STEMI. You're gonna call the cardiologist to come and stent the patient. Now, one important thing about left bundle branch block is that left bundle branch block is like a pacemaker. So when you have a left bundle branch block, you cannot read the ECG anymore. Meaning that if you do a stress test, you cannot look for ST elevations and ST depressions in those patients. So those patients are really difficult to identify ST segment changes because left bundle branch block itself can give you ST changes. So in those patients, if the question came in the exam, a patient with angina, and you would like to do a stress test and you found left bundle branch block on the ECG, you do a nuclear test to see if the patient has has ischemia, and then you go for PCR. So again, this is a ECG of you see a white complex here, white complex here, white complex here. You go to V1. This is white complex. The QR is going up. This is left, right. This is right bundle branch block. So that's the first part of the ECG session. We're going to have a 5-minute break. Whether you want to continue. Guys, what do you want?
Doctor, if you don't want a break, I think we can carry on.
But I have a question first, if that's fine.
Yes.
So you said if it's going down, then it's right or left?
No, if it's going down, that's left. If it's going up, it's right. The right is يعني اليد اليمنى أقوى من اليد اليسرى، فاليد اليمنى تروح فوق.
Thank you.
Okay. So arrhythmias. Now, arrhythmias are the most challenging thing in ECGs, but I'll try to simplify it for you. So abnormal heart rhythm. So it can be tachyarrhythmias, which is heart rate more than 100. It can be bradyarrhythmias, heart rate less than 60. So we have general rules in arrhythmias. The first rule is shock the fast and pace the slow. If you have a bradycardia, you do pacing. If you have a tachycardia, you shock the patient, you give electricity to the patient. If the patient is unstable, you shock or pace, okay, according to the rhythm. But that's the only indication. You shock the tachycardias if they are unstable. Now, what does unstable mean? Ischemic chest pain, heart failure, hypotension, altered mental status because of the arrhythmia. So if a patient presented with arrhythmia, you saw the ECG is abnormal, you have a tachyarrhythmia, and the patient is complaining of a severe crushing chest pain. So that qualifies as a criteria to shock the patient. So if you saw that, then that patient has to be shocked because this patient is unstable. If you have a patient with heart failure, new onset heart failure, because of that arrhythmia, then you cardiovert them or you shock them. Okay, so remember, chest pain, shortness of breath, hypotension, confusion, altered mental status. Now, the last thing is do not shock sinus tachycardia, because the whole point of shocking is to restore the heart back to sinus rhythm. If you have a sinus rhythm, then that's, and you cannot shock the heart, because if you shock that, it's already normal. You're not gonna make it more normal than it's already is. So tachycardias. So tachycardias can be narrow QRS, and then it can be narrow or wide. So if it's narrow, look for the regularity. Is it regular or irregular? So if it's regular, it's one of three things. It's either sinus tachycardia, it's SVT or atrial flutter. If it's irregular, it's either atrial fibrillation, atrial flutter, or multifocal atrial tachycardia. If it's wide QRS, if it's regular, if that's ventricular tachycardia, you have other things as well. If it's irregular, you have atrial fibrillation with aberrancy or with WPW. The things that the things that are in yellow, those are the things that I'm gonna cover. Those are the things that are common in exams. The things that are in white, I just put them out to see that there are many things in each entity, but I'm only covering few basic things. So let's talk about narrow complex regular tachycardias. So identify the rhythm, ask yourself what are the atria doing. So if you saw a PQRST complexes, that's sinus tachycardia. If you saw there were no P waves, or P waves and T waves are joined, then that's going to be SVT, supraventricular tachycardia. So let's see this one. So the first thing, this patient is tachycardic. You can see the heart rate. So to calculate the heart rate, look at the first QRS in the line. The second is going to be, this is 300, this is 150. So it's less than 150. So it's tachycardia. So this patient, you can see in the ECG that we have P waves. You have a QRS, you have a T wave, P wave, QRS, T wave, P wave, QRS, T wave. So that is sinus tachycardia. So this patient presented to you with sinus tachycardia. What are you going to do? Basically, you're gonna look for the other cause. What causing this tachycardia? Maybe the patient is anemic. Maybe the patient had a panic attack. Patient has a PE. So look for the cause. Do not shock this patient. Look at this. Now, this another patient presenting with this. So what you do? You have a tachycardia. You look at the QRS. There's no P wave. There is a T wave. Or maybe this is a P wave, I don't know. But there's a wave here. QRS, wave here, QRS, wave. So we have a P wave or a T wave and QRS. We don't see like the PQRST segment. So this is VT. This is supraventricular tachycardia. Now, if this patient presented to you, you're gonna ask yourself, this patient, is the patient stable or unstable? Does the patient have chest pain, shortness of breath, hypotension, confusion? If not, then that patient is stable. So in stable patients, you give them adenosine. you start with carotid massage and you start with vagal maneuvers, then you give adenosine. If it didn't work, you give another adenosine. If it didn't work, you give another adenosine. If it didn't work, then you go for other agents, such as beta blockers, calcium channel blockers, and digoxin. But that's, this is not the scope of the lecture. Now, we cannot talk about SVTs without talking about pre-excitation. And that for third years, this is your PBL case. So what you see here, just ignore this picture right now, just focus on here. So we have an SA node, an AV node. The SA node is gonna transmit signals to the AV node, and the AV node is gonna supply the ventricles, and you get then the normal P, R, P, QRST, ECG. Now look at this picture. So you have an SA node, and you have an abnormal bundle. You have abnormal pathway between the atria and the ventricle. So what happens is you're gonna receive, the innervation is gonna come out of the SA node, going to the AV node, and it's gonna go to the accessory pathway as well. So this part of the ventricle is gonna be innervated or supplied by the accessory pathway, and this part is gonna be supplied by the AV node. So accessory pathway is gonna come like from here, and the AV node is gonna come from here. They're gonna meet, but nothing is gonna happen. So what you see in ECG, you see a short PR segment, and you see a delta wave, a bit upsloping of the QRS. So delta wave and the short PR segment, that's pre-excitation, or that is what we call it the WPW, Wolff-Parkinson-White syndrome. So what happens in WPW? Why it's important? It's important because this is what happened normally. So you have an auxiliary pathway. So you get the SA node is gonna supply the AV node, and gonna supply the accessory pathway. They're gonna meet. Nothing is gonna happen. So this is a resting ECG. Now, when an event happen, don't worry. What is the event? So sometimes you can get like abnormal beat from the atria. That's 30% of your heart rate is like that. So that's nothing to worry about. That's normal. But in those patients, when you get that, what you get is you have an abnormal beat coming, and that abnormal beat is gonna innervate the AV node first, and that AV node is gonna come and go to the ventricle and then re-enter from the accessory pathway and go back to the AV node. So the pre-excitation is gonna lead to supraventricular tachycardia. You don't have to know this, okay? This is just the general information to understand the pathophysiology. You're not gonna get asked about it. Even when you read in books about arrhythmias, they're gonna say antidromic or orthodromic AVNRT or AVRT. This is not important for your level at all. So that's the ECG of pre-excitation. Very clear delta waves, very clear short PR intervals. Look at this. Delta wave, delta wave, delta wave, delta wave. So when you are in doubt if this is a delta wave or not, look at the PR segment. If the PR segment is normal, then that's not a delta wave, that's not pre-excitation. If delta wave, if the PR intervals are short, then that's a delta wave. And that's WPW. Now, when you get the WPW patient, when they get an abnormal beat of the heart, they go to arrhythmias, they go to SVT. So look at this. You see a one wave like P wave or T wave, and between them a QRS. Short wave and QRS, P wave or T wave, QRS. You don't see P, T, you don't see a P wave and QRS and T wave. So this is SVT. So in this patient, if the patient presented to you with this, you're gonna ask yourself, is the patient stable? If the patient is stable, you're going to use adenosine and carotid massage or vagal maneuvers. If it didn't work, in case of SVT, the adenosine is going to work. Adenosine is the treatment in these patients. So in WPW, I mean stable WPW, a patient with a stable WPW, the patient with this ECG, the way you treat it, you take them to you do an electrophysiological study, you identify the bundle, and then you ablate it. Okay, you use electricity like cuttering. You ablate that segment. The patient is going to be okay. Now, and there are a few things in a stable WPW. So in a stable patient like this, if you give them adenosine, beta blockers, digoxin, or calcium channel blockers, they're going to deteriorate. The patient is going to deteriorate. Why? Because when you do that, you block the AB node, and then you make all the electricity from the the SA node go through the accessory bundle, and that is going to lead to ventricular tachycardia or maybe ventricular fibrillation. So don't use those agents in a patient with a stable WPW. If a patient presented with SVT, then yes, you have to use them. So that was narrow-complex regular tachycardia. Now we're going to go to the most common, the most challenging tachycardias. So to identify the type of tachycardia, again, look at the P waves. So if you saw there were no P waves and there are only oscillatory waves, then that's atrial fibrillation. If you saw sawtooth P waves, we call them flutter waves, then that's atrial flutter. If you saw 3 different morphologies of the P waves, then that's multifocal atrial tachycardia. Let's look at the ECGs. So what do you see here? You see the first thing that catches your eye is that the patient has an irregular heart rate, irregular ECG. So it's narrow complex, irregular, so it has to be one of the three things. It's either atrial fibrillation, atrial flutter, or multifocal atrial tachycardia. So look at the P waves. Do you see any P waves? I don't see any P waves. They're all oscillatory waves. They're all oscillatory waves. There is a T wave, but there is no P waves. So that's atrial fibrillation. Look at this. Again, the same thing. You have a fast ECG, you have a fast rhythm. You look at the QRSs, they are short, they are narrow. So this is a narrow QRS, tachycardia. Is it regular? No, it's not, because you can see here, it's not regular. So that's either one of the 3 things: atrial flutter, atrial fibrillation, multi-atrial focal tachycardia. Now look, this is a T wave. Okay? There is no P waves here. So look for the long segments, like the long pauses between 2 RRs, and see if you have P waves there or not. So we don't have P waves here. This means that this patient has atrial fibrillation because there are no P waves here. Those might be P waves, might be T waves. I cannot know. So look for things for a long RR interval, so you can identify if there are P waves or not. So that's again atrial fibrillation. Now let's look at this. So what you can see, I don't know if it's clear to you. You have a narrow QRS, but you have irregular rhythm. So look at this. The space from here to here and space from here to here, definitely longer. So this is an irregular rhythm. So it's either 3 things: atrial fibrillation, atrial flutter, multifocal atrial tachycardia. So there are P waves, so that's not atrial fibrillation. So it has to be one of the two, atrial flutter or multi-atrial focal tachycardia. So look at the P waves. Look at this morphology. Look at this shape of the P wave, and look at this shape, and look at this big P wave, and look at this inverted P waves. So more than 3 different morphologies of a P wave. That is multi-focal atrial tachycardia. Now, those patients in the exam, you're going to have a patient with respiratory disease. So you're going to have a pneumonia, COPD, emphysema, asthma, idiopathic pulmonary fibrosis. You're going to get something with lung. So in those patients, treat the lung condition, you treat the rhythm. The last thing is pretty obvious. So you have irregular heart rate. The RR interval here is longer, is shorter than the RR interval here. So you look at the P waves, you can see them. They are very fast occurring. Then the depolarization occurs slowly. Then again, that is atrial flutter. You look at a tooth wave like P waves. So this is atrial flutter. That is it. One point to know that atrial flutter and atrial fibrillation, those are the two arrhythmias that need anticoagulation. Both those two arrhythmias can give you, they can form thrombi in the left atrium, and they can lead to strokes. So both of them need anticoagulation. Others, they don't. Now, again, management, the same thing. If the patient is unstable, you shock the patient. If it's stable, you treat them with beta blockers, calcium channel blockers, or digoxin. Let's look at the final thing in tachycardias, ventricular tachycardia. So ventricular tachycardia is going to be white and it's going to be regular. So we divide them into monomorphic or polymorphic. So monomorphic meaning that the QRSs do not change between each beat. Polymorphic, the QRSs are changing. Now, if you have a polymorphic VTAC or VT, in a setting of a long QT prolongation, we call that torsade de pointes. Now, how do I know that this is the QT is prolonged or not? That's beyond the scope of our lecture. Just know polymorphic VTAC is going to be torsade de pointes 99% of the time if you saw it. So this is the ECG. What you see here is a wide complex rhythm. You can see it's tachycardia. So you cannot really identify any P waves here. You cannot identify any T waves here. What you can see is only very long QRSs. So that's ventricular tachycardia. Now look at the QRSs. They are same. That's the shape of the QRS, the amplitude of the QRS is the same throughout. So that is going to be ventricular tachycardia, which is monomorphic. Treatment, use amiodarone, procainamide, anything that affects the ventricle. Flecainide, other things. Now look at this. Just forget this part of the rhythm. Focus on the middle thing, on the middle part. So what you can see, a wide QRS, and that wide QRS is changing. So this is a small QRS. That's a big amplitude QRS. This is more wide. So this is a polymorphic VTAC, a polymorphic ventricular tachycardia. In that patient, if the patient presented with polymorphic ventricular tachycardia, the first step is going to be, of course, if the patient is unstable, you're going to shock the patient. But in this patient, the first step in polymorphic VTAC is going to give is to be giving magnesium sulfate, because in patients with torsade or patients with polymorphic VTAC, most probably they're having a long QT. So magnesium sulfate is going to shorten the QT interval, and they're going to treat. It's going to treat the ventricular, the polymorphic ventricular tachycardia. So this is, again, what you see here is a ventricular tachycardia, which is changed. The QRS is changing. Now look at this here. So look at this is the T wave. Look at the T wave is very prolonged. Look at the T wave here. It's very prolonged. So that is torsade pointes. The last and the final part of our presentation is going to be bradycardia. Let's go over this. So when you talk about bradycardia, you're going to have a sinus bradycardia, first of all, which is a PQRS, T waves, but it is bradycardic. The heart rate is very slow. And the chances of getting a sinus bradycardia in exam is very low, because there is no much things to ask about in sinus bradycardia. But what you're going to see in exams and what you have to worry about in life is AV blocks. So first, AV blocks, they're divided into first, second, and third degree. So first degree AV block is going to have a prolonged PR interval. That's it. Second degree AV block is divided into two types, type 1 or type 2. So in MOBIS 1 or type 1, you're going to have an increasing PR interval and a drop beat. In type 2, you're going to have a steady PR interval and a drop beat. In type 3, you're going to have no dissociation between the P and the QRS. We call that complete heart block. So draw a line here. The first and second type 1, they are benign, nothing to worry about, no treatment is necessary. Second degree type 2 and third degree, they need a pacemaker. So this is a diagram that show you what are you going to have. So in first degree AV block, we're going to have only a prolonged PR interval. In second degree, MOBIS 1, you're going to have an increasing PR. Look at this PR interval is small. This is increasing. This is more increasing, and then a drop beat. Second degree AV block, you're going to have a steady PR interval. Whether it can be prolonged, it can be normal. So a steady PR interval, and then a drop beat. Don't worry about the third one. The third degree AV block, you're going to have a complete dissociation. So look at this. What do you see? What you see here, this is the PR interval. This is the P wave, and this is the PR interval. You can see it's very prolonged. Now look at this. Look at this patient. So what you see here, you can see a PR interval here. So this is the P wave, and this is the QRS. And you can see that the P wave in the second beat, the PR is prolonged so much to the point that the P wave is going inside the T wave. Look at here, the PR prolonged too much that the P wave is getting inside the T wave here as well. So that is prolonging PR interval, and then you have a drop beat. Same thing. PR interval, and that prolonged more, getting inside the P wave, and drop beat. So this is type 1. Here it's even more clear. So you can see a short PR, prolonged PR interval, and then that's more prolonging, and that's more prolonging. That is second degree type 1. Now here, a PR interval, which is steady, then a PR interval, both of them, they are the same. And then you have a P wave and drop beat. The same P wave and drop beat. So the trick is, whenever you see a bradycardia, you look at the ECG and you see if it's regular or not. If it's not regular, then that's definitely type 2, either type 1 or type 2. Then you look for the PR interval. Are they increasing? If they are yes, increasing, then that's type 1. If it's not, then type 2. AV block. Second type is the only AV block is going who's going to give you an irregular irregular ECG or irregular rhythm. Now here is the third degree heart block. So what you can see, this is the T wave. So this is a P wave. And you can see there is a bit of a wave here in the beginning of the QRS. And there's another P wave. That's another P wave. That's another P wave. That's another P wave. That's another P wave going inside the T wave. That's another P wave. That's another P wave. So the P waves are occurring in regular intervals, while the QRSs are going at the regular intervals in a different rate. So this is complete heart block. The last thing, hyperkalemia. Now, hyperkalemia, they're very this abnormalities are very common in life, so you need to know them, and they give you a hard time usually in exams. So what you see here is a peaked T waves, a white QRS complex, a prolonged PR interval, and then you get a sine wave. You have what they call them the 4 B's of hyperkalemia: broad, blocks, bradycardia, and bizarre. So any case of a bradycardia or AV block, look for hyperkalemia. Any case of a broad ECG, look for hyperkalemia. Any case of a bizarre, weird ECG, look for hyperkalemia as well. I had a picture, I don't know where it went. So those are the practice tests. I need a volunteer now. Like I have 7 cases and I need, for each case, I need a volunteer. Do you want to take a break while you want to continue? Guys. شكلكم راقدين. Guys, someone, do you want to take a break? Okay, who's going to start case 1? Guys, يعني I need someone to. Hello. Roda, please, can someone answer? Okay, so let's take a break, 5 minutes, and then come back. because I don't know يعني انتوا شكلكم. Then if you don't want to do the practice test, we can end the session now. So at 11:05, 11:10, we're going to come back and finish the practice test. Okay, guys, can we continue?
Yes, doctor, we can continue.
Okay, sorry, I need someone to do the cases with me, yani.
I'll volunteer to do it, doctor.
Okay. So, case number 1, a 50 years old male presented with chest pain. He has a past medical history of hypertension, dyslipidemia, diabetes, and he is a smoker.
Okay.
So this is the ECG.
Okay. So I can see that the patient has he's normal in terms of rate. It's approximately 350.
Yeah, it is normal.
Yeah. And the rhythm is regular. However, the striking feature in this ECG is that there are ST elevations in leads V1, V2, V3, V4, and V5.
Yes, and so what do you call that?
Anterior septal MI.
Yes, exactly. So that is a case of anterior septal MI. So what you're going to do for this patient? Sorry, which year are you?
I'm a senior year.
Okay,
Senior year.
so tell me exactly what are you going to do for this
So I'm
patient?
going to admit the patient and start him on morphine, activate the cath lab, oxygenate the patient, and give him sublingual nitroglycerine.
Okay, you forgot the most important thing is aspirin. So you're gonna give aspirin. You're
Yes.
going to give the nitrates. You're gonna give heparin. You're going to call activate the cath lab, oxygen and morphine if required. Okay, well done. Let's move to the second case. Another volunteer, please. Guys, I need another volunteer.
Okay, doctor, I will volunteer. Can you
Okay.
hear me?
Yes, I can.
Okay.
So a 27 years old female came with palpitations. The patient is having a central chest pain. She is alert and oriented. BP is 110/65. The examination is unremarkable. So the ECG is shown. So what is the treatment? So this is the ECG. So let's take me through your steps of determining what is the diagnosis of this patient.
First, the very high rate, around 150.
Yes.
It is regular. Wide complex tachycardia.
Yes.
Is the patient, you mentioned chest pain, is it crushing chest pain like or ischemic
No.
pain?
No, it's just mild chest pain. She
Okay.
has chest pain.
No symptoms of pulmonary edema or other
No.
instabilities? Okay.
No.
So it's a wide complex regular tachycardia. In that case, give her amiodarone.
Exactly. You're gonna give her amiodarone, procainamide, other things, and then that will settle the arrhythmia. So this patient has a ventricular tachycardia.
Yeah.
Okay. بس يعني well done. And that's in the exam. Sometimes they try to confuse you. It tells you central chest pain. So what does central chest pain means? And it's not ischemic. So ischemic chest pain is the one you do you shock the patient for. So well done.
Okay, thank you.
The third case. I need a volunteer. The ECGs are easy. I need a volunteer. Okay, guys, anyone who wants to do the ECG, even if
Yeah, doctor, I will do it again.
okay, that's okay. So 74 years old male known to have diabetic, dyslipidemia, hypertension, heart failure, presented with history of chest pain. The chest pain is mild. Patient is stable vitally. Examination reveals bilateral lower crying crackles. ECG is shown. What's your diagnosis and treatment?
Okay, so first, it's regular.
Mhm.
Rate is around 150 beat per minute.
Mhm.
So he's tachycardic.
Mhm.
Um, we'll see the B wave is present. QRS is normal. ST segments. Let me check.
But there are no P waves here. There are non-well formed P waves. Yeah, I know they're not very clear, the P waves. So
No,
we don't.
The small ones before the QRS.
Yeah, but that the P waves has to be like a very clear one. It's not just a very small. It has to be a wave. Okay, it's
Okay,
not
I see.
مش بس في نقطة صغيرة لازم يكون wave. So
Okay.
that there are no P waves here.
Okay, then it's
And
SV. It's irregular. QRS waves are irregular.
so
It's so neurocomplex tachycardia irregular. So in that case, he's unstable. So I will shock him.
no. So wait. So
Mm.
it's so what is your diagnosis? So it's only three.
Mhm.
Only flutter or
Atrial
atrial
fibrillation.
fibrillation or multifocal atrial tachycardia. So that clearly is atrial.
Atrial fibrillation.
Exactly. So this is atrial fibrillation. Always, when you see a narrow irregular tachycardia, you look for the longest RR interval, and then you see the P waves there. Don't because here I cannot know this is T wave or P wave. I don't know. Here this is a T wave or a P wave. ما أعرف. So look for the longest RR, and then you see the P waves there. So exactly, this patient has an atrial fibrillation. So this patient is known to have heart failure. So patients with heart failure already have crackles on the. They have already crackles.
Okay.
So this patient presented, he's stable. So what are you going to do? What is the treatment? So you're going to give beta blockers, calcium channel blockers, any other rate control drugs to slow the heart rate down.
And monitor the patient.
Of course. Case 4. Anybody يعني حتى لو اللي مسوينا اللي participated before they can participate. Any new participant?
It's okay, doctor. I can go ahead if no one
Okay.
answers.
Okay. A 34 years old male admitted for pneumonia. He was treated with antibiotics. In the night, the nurse called you because the patient is having palpitations and discomfort in the chest. You do an ECG. So what's the treatment and what's the cause? Oh, it's very bad ECG, sorry. So what do you see here?
Okay, so I see tachycardia, but it's irregular.
No, look at here. This is segments. This is a normal resting. Yeah, look at this.
Doctor,
so
is
it
this
is regular.
first
Is
side?
this what? Yeah. So this the ECG is regular, but it's polymorphic.
Yes.
So the QRSs change with time, and that is Torsat, as you said. So
Yes.
what are you going to give the patient?
Administer
The patient is stable.
Magnesium.
Magnesium sulfate, exactly. So what is the cause of the patient symptoms? He was pneumonia and he was receiving antibiotics. So which antibiotic can cause this? Okay, so fluoroquinolones and macrolides, they can give you long QT and they can cause Torsat. Okay.
Okay.
Case 5. A 23-year-old female presented with palpitations. The patient is stable. You do an ECG. What's the management? So that's the ECG.
Narrow complex tachycardia.
Mhm.
It's most likely a supraventricular tachycardia.
Exactly. So what are you going to do to the patient? The patient is stable.
Administer the patient adenosine.
Exactly.
No, we start
You
with
do
the
it.
conservative first. You
Okay.
start with the carotid massage and Valsalva maneuver as well to increase
Yeah.
the pressure. If it
Yeah.
didn't work, you can administer the patient adenosine. And then you can repeat adenosine for 3 times, 3 different doses.
Yeah. So the point is, you don't really wait for carotid massage. You write the order. You prepare the adenosine.
Yes.
And then while you're doing that, you tell the patient to blow in a bag, or you tell the patient to do a carotid, or you do a carotid massage to the patient. And then if that didn't work, you're going to give adenosine. But the mainstay of treatment is adenosine, because carotid massage works in a small amount of cases. It's not very good
Effective.
treatment, but
Yes.
it will save the patient from receiving adenosine.
Yes.
That's the most important thing. Okay. So case 6 is a spot diagnosis. So what is this? Okay, so you see it's a bradycardia.
3rd degree block.
Block, yeah.
Exactly. How did you know that this is 3rd degree? Because you see,
There's a
P waves.
association.
Yeah, and there is a
The
P waves
area
here. There are P waves inside the complex. P waves here, P wave here, P wave here, and there is QRSS. So that's 3rd degree heart block.
Yes.
So the last case, a 6-year-old male, end-stage renal disease, who missed his dialysis session. So this is ECG.
Hyperkalemia.
Yes. So look at this.
VTAC.
This is this is very bizarre ECG. Look at this. Very wide.
Yes.
Sine. Look, those are the zigzag or the sine waves that are typical for hyperkalemia. So
Yes.
those patients are patients with hyperkalemia. So what is the treatment for hyperkalemia?
Start with insulin and calcium gluconate.
First of all, calcium gluconate to stabilize the heart.
Yes.
Then
Dialysis.
you give insulin. You try to treat it with medications. If you can't, then you do dialysis. In this patient, because the patient is already on dialysis, you might dialyze the patient.
Yeah.
But in typical exam scenario, you're gonna treat with medications first.
Yeah.
So that's basically the ECG lecture. I'm sorry if I can't. I'm going so fast, or if I confused you. If you have any questions, please ask me. I'm sorry I didn't pay attention to the comment section. So if you have any question, even in the comments, you can write. So we can answer them.
Doctor, thank you so much. This was very useful. It was a very good review for us. So thank you for your efforts as well.
Yes, thank you
Welcome.
so much. Thank you.
You're
We
welcome.
appreciate it.
Any questions? Okay, so I think there are no questions. So please, when you're studying for internal medicine rotation or even the cardiology module, they really love to ask about atrial fibrillation. They really like to ask about management of different arrhythmias. So please know the management for arrhythmias and especially atrial fibrillation. And please, before answering pericarditis, if you saw ST elevations, think of MI first, then try to, if you saw a diffused ST elevations, think of MI first. And if in doubt, look at the PR segments. And if they're changing, then that's pericarditis. But most probably they're gonna give you MI, okay? So please be careful of that. And then thank you. في سؤال أظن. It was clear. Thank you. Okay.
Thank you
So
so
thank
much.
you. I hope I see you in other sessions. Okay. Thank you.
Inshallah.
Bye.
Thank you so much. Bye, doctor.